Thank you for that introduction. Good morning. My name is Katherine Bingmer. I'm a surgical resident at University Hospital's Cleveland Medical Center. Today I'll be presenting is the increase in number of laparoscopic procedures affecting surgical open experience. I have no disclosures to report, and the disclosures of our other authors are as listed. Although minimally invasive surgery has existed in an academic sense for over 100 years, it began to be widely used by general surgeons in the 1990s. With this explosion of new procedures, it soon became apparent that training surgeons needed focused education on these new techniques. Initiated by SAGES and accepted by the American Board of Surgery, fundamentals of laparoscopic surgery, and more recently endoscopic surgery, were created to supplement surgical resident education. These curricula with written and practical tests are now mandatory for every graduating general surgery resident. But has the pendulum of focused education swung too far in the direction of minimally invasive surgery? FLS began as an attempt to assist residents in learning new technology that they had limited exposure to in training, but we observed that the breadth and depth of minimally invasive surgery continues to grow. Presumably, there was never an attempt to supplement open surgical technique training because residents have adequate exposure to these in residency. As more open procedures are replaced with minimally invasive ones, will we reach a time when experience alone cannot be relied upon to ensure residents are sufficiently trained in safe and efficient open surgical technique? We are not the first group to ask the question like this. Previous studies have shown the precipitous drop in the number of open cholecystectomy and other biliary procedures being performed by surgical residents. And open appendectomies are now so rare, one study advocated consideration of elective open appendectomy in appropriate patients for the benefit of resident education alone. A study of Accreditation Council for Graduate Medical Education case logs from 2000 to 2011 concluded that the number of open abdominal procedures performed by surgical residents declined significantly over that time. Based on our own observations and studies showing the decline of open surgery in the early 2000s, our aim was to examine the relationship and trends for open and laparoscopic procedures performed by general surgery residents. So this study was performed using ACGME case log data. The data available to us was the average number of cases performed by graduating surgical residents from 2000 to 2018. We focused on 5 procedures: anti-reflux, appendectomy, colectomy, inguinal hernia repair, and splenectomy. These cases were chosen because they cover a wide range of general surgery procedures and occur frequently enough, and most residency programs, they represent a broader resident experience and recorded every year in the case log report. The next few slides show the average number of procedures performed by graduating surgical residents over time. Shown here is the anti-reflux procedure. In 2000, residents on average were performing equal numbers of open and laparoscopic anti-reflux procedures. However, by 2018, they're performing the same number of procedures overall, but almost no open cases. In 2000, graduating surgical residents were performing over twice as many open as laparoscopic appendectomies. However, by 2007, they were performing more minimally invasive appendectomies than open, and the gap continues to widen every year after that. Graduating general surgery residents report performing more open than laparoscopic colectomies every year from 2000 to 2018. However, around 2008, we notice a rise in laparoscopic colectomies that continues over the next 10 years and is accompanied by a decline in open colectomies being performed. Inguinal hernia repair has seen a large increase in the number of laparoscopic cases, particularly in the last 10 years. However, this does not seem to have affected the number of open procedures being performed too much, as graduating residents perform 45 or more cases at the time of graduation every year the past 19 years. Open splenectomy has seen a decrease since 2000. While the number of laparoscopic splenectomies has increased, overall graduating residents are performing fewer splenectomies than they did in 2000. We postulate this could be due to several reasons, including the widespread use of splenic artery embolization in trauma patients. So we wanted to know if these changes were significant over time. To do this, we grouped the data into time periods, the time periods shown here, and compared the average procedures performed by graduating residents by time period, one time period to the next, to see if the change was significant. This graph is showing the change in the average number of open procedures performed by surgical residents in each time period. From left to right, we can see that anti-reflux has a significant decrease with every time period, as does appendectomy. Colectomy has a significant decrease from 2010 on, and inguinal hernia has a significant change with each time period, first decreasing, then increasing, and then decreasing again, and splenectomy has a significant decrease over time. So this graph is showing the change in average number of laparoscopic procedures performed by surgical residents. Again, from left to right, anti-reflex has a significant increase from 2010 on. Appendectomy has a significant increase with every time period, as does colectomy and inguinal hernia repair. And splenectomy experienced first an increase and then a significant decrease. So why does this overall increase in laparoscopic procedures and decrease in open procedures over the last 19 years matter? As we showed previously, the emphasis in surgical education has been on minimally invasive technique. We say this not only in reference to FLS and FES. The American Board of Surgery and ACGME have changed the case log minimum requirements to include, among other things, an emphasis on laparoscopic procedures. Residents now need 100 basic and 75 complex laparoscopic cases logged to graduate. We worry that the surgical experience in open technique is being eclipsed by laparoscopic procedures, and that the educational gap has not been filled with other modalities to teach procedural skills and assure proficiency. We have shown that the number of open procedures being performed by graduating general surgery residents continues to decline, and that despite this, the focus of the governing bodies of surgery continues to be on minimally invasive technique. We worry that in the future, open surgical experience may be reduced to a volume that necessitates formal supplemental surgical education. Thank you, and I'm happy to take any questions.